Have you ever felt just completely swamped by the sheer amount of information you need to juggle in nursing practice? I mean, patient safety, quality care,
Yeah.
it's all on the line constantly. How do nurses actually keep track of everything that's vital?
It's a huge challenge, definitely. And that's exactly why we're doing this deep dive today. We're focusing on the heart of it all, nursing documentation and informatics.
Okay.
We're drawing insights from the Potter, Perry, Stockard, and Hall Fundamentals of Nursing textbook, the 11th edition. Our goal, to give you a clear, engaging summary of the essentials, focusing on how you can actually apply this stuff in practice, connecting it back to NCLEX competencies too.
So this is basically your shortcut to getting a solid grip on it all. We want those aha moments for you, understanding not just the what, but the really crucial why behind these responsibilities. All right, let's unpack this then, starting with the basics. What is documentation, fundamentally?
At its core, it's simply the written record of pertinent patient data. Think clinical decisions, interventions, how the patient responds. It all goes into the health record.
Whether that's electronic, paper, or, a mix of both.
Exactly. And it sounds simple, but it serves so many critical purposes. First off, interprofessional communication, this record. It's the main way the entire healthcare team stays connected.
Okay.
Doctors, therapists, other nurses. Everyone uses it to understand the patient's needs, their responses, the decisions made. It helps ensure care is safe, effective, and truly patient-centered.
So without it, things get messy fast.
Oh, absolutely. Lack of communication leads to fragmented care, missteps, and unfortunately, errors. The record is that single source of truth everyone relies on.
It's like the ultimate communication hub, making sure everyone's on the same page.
Precisely. And beyond that, it's also your legal record. Strong, accurate documentation. That's your best defense if any legal questions come up about the care provided.
Right. It shows you met the standards.
Or even exceeded them. It provides clear evidence of the care process.
That's a really important layer of protection for nurses. But I've also heard it significantly impacts the hospital's finances.
It absolutely does. Documentation is crucial for financial billing and reimbursement. Hospitals depend on accurate charting to get paid. For instance, Medicare uses diagnosis-related groups, DRGs, to classify patients and determine payment amounts.
Okay.
And here's a really key point for nurses. Since 2008, CMS, that's the Centers for Medicare and Medicaid Services, they don't reimburse hospitals for certain hospital-acquired conditions, sometimes called never events.
Never events? Like what?
Think specific things that are considered preventable with good nursing care. Stage 3 and 4 pressure injuries that develop in the hospital, falls that result in injury, catheter-associated urinary tract infections, CAUTIs, and central line-associated bloodstream infections, CLAB-BIs.
Wow.
Yeah. If these happen, and your documentation doesn't clearly show they were present on admission, or if the preventive care wasn't documented properly, the hospital might not get reimbursed for treating them.
So my charting directly impacts whether the hospital gets paid for potentially very expensive care.
That's exactly it. Your accurate documentation tracks patient progress, shows how events developed, and ultimately influences reimbursement and patient safety. It's a powerful link.
That really drives home the importance. What else are these records used for?
Well, they're essential for auditing and monitoring. Regulatory bodies like the Joint Commission, TJC, and CMS audit records regularly. They're looking at the quality and appropriateness of care, trying to spot recurring problems.
To improve things overall?
Exactly. It guides quality improvement initiatives, staff development, things like that. It's a feedback loop for the whole system.
And I bet they're incredibly useful for learning, too.
Definitely. They're a fantastic resource for education. For students like you, studying records provides real-world examples of conditions, patient responses, treatment effectiveness. It helps build that clinical knowledge.
Makes sense.
And for research, de-identified data from health records is invaluable. It's used for statistical analysis, contributing to evidence-based practice. Like, researchers might study if getting patients up and walking early really does decrease post-op complications using data pooled from thousands of records.
Okay, so the records serve a ton of purposes. But what happens when documentation isn't done correctly? The stakes seem incredibly high.
They absolutely are. Improper documentation is a major factor in malpractice claims. Common mistakes include things like failing to record important health or medication info, not documenting nursing actions taken, forgetting to chart medication administration or patient reactions to meds.
Things getting missed.
Right. Or even failing to note changes in a patient's condition, writing incomplete or illegible notes, or not documenting when a medication was discontinued. Any of these can have serious legal consequences.
So how do nurses ensure their documentation is legally sound? Are there specific rules?
Yes, there are clear guidelines, like those outlined in Table 26.1 in the textbook. First, always stick to objective, factual observations. What did you see, hear, palpate, smell? If you include something the patient said, use direct quotes.
Got it. Factual and objective.
Correct errors properly. Never erase or use whiteout. Just draw a single line through the mistake, write error next to it, and add your initials or signature in the date time.
Simple fix.
Record all relevant facts. Thoroughness is key for demonstrating adequate care. Document any discussions you have with providers, especially if you're clarifying orders. Critically, only document care that you provided with very specific, limited exceptions.
Okay, only chart for yourself.
Avoid vague terms like status unchanged or appears comfortable. Be specific. And always, always start each entry with the date and time and end it with your signature and professional credentials.
Clear, concise, attributable. Makes sense. Now, what about patient privacy? That's obviously a massive concern.
It's paramount. Nurses have a strict legal and ethical obligation to maintain patient confidentiality. Access to a patient's health information is strictly limited to members of the direct care team.
So only those actively involved in that specific patient's care.
That's right. Sharing information, even casually with other healthcare staff not directly involved, is a breach of privacy and trust.
And this is where HIPAA comes in, right? The Health Insurance Portability and Accountability Act.
Exactly. HIPAA, enacted in 1996, was the first major federal law protecting patient records. It has two main parts we need to know. The privacy rule, which limits how health information can be used and disclosed.
Only for specific purposes, like treatment, payment, or operations.
Correct. And only the minimum necessary information. Then there's the security rule, which mandates specific administrative, physical, and technical safeguards to protect electronic protected health information, or PHI. It covers 18 specific identifiers.
So how do systems actually protect this electronic data?
There are multiple layers. Logical safeguards include things like automatic computer sign-offs, robust firewalls, up-to-date antivirus software, and strong passwords that need to be changed regularly and never shared. Every access is tracked through your unique user login.
Okay, so the system knows who's looking at what.
Yes. Then there are physical safeguards. Things like keeping computers in restricted areas, using privacy filters on screens that might be visible to others. Although mobile devices like tablets and phones present challenges here because they're easier to lose or misplace.
So even with all the tech, basic vigilance is still key for the nurse.
Absolutely. When it comes to handling and disposing of information, you have a fundamental duty to protect any printed PHI. That includes things like your daily work lists or patient assignment sheets.
What do you do with them?
When you're done with them, they need to be destroyed securely, usually by shredding or placing them in locked disposal bins. For nursing students, this is critical too. Any paperwork you generate for clinicals needs to have patient identifiers removed, de-identified, and any printouts must be kept secure and destroyed properly afterwards.
Even faxing needs care, right?
Yes, faxing PHI requires specific steps for security. Always use a cover sheet, double-check the recipient's fax number, make sure the fax machine itself is in a secure location, follow your agency's policies, and ideally confirm the recipient got it.
All right, so we've covered the why and the legal privacy aspects. Let's pivot to the how-to of actually writing excellent documentation. What makes documentation good?
Quality documentation is really about enhancing efficient, individualized care. It also needs to meet standards set by organizations like the Joint Commission and NCQA. They want to see documentation that clearly shows the nursing process, your clinical decision-making, any patient or family teaching, and discharge planning.
So how do we achieve that? Are there specific characteristics?
There are. Think of them as the 5 pillars of quality documentation. First, it must be factual. Stick to clear, objective observations. What did you actually observe, hear, palpate, smell?
Avoid opinions or interpretations.
Exactly. Avoid words like appears or seems. Instead of writing patient seems anxious, you document objective data that supports that assessment. For example, heart rate 110, respiratory rate 22. Patient states, I feel really nervous right now. You back up subjective statements with objective findings or direct quotes.
Makes sense. What's next?
Second, accurate. This means using precise measurements whenever possible. Intake 360 milliliters of water is much better than patient drank adequately.
Be specific.
Yes. Describe changes accurately. Instead of large abdominal incision healing well, you'd write something like abdominal incision site approximated 5 centimeters in length without redness, drainage, or edema. Give the details.
And abbreviations. I hear those can be tricky.
Very tricky and incredibly important for accuracy. You should only use abbreviations approved by your facility, and you absolutely must know and avoid TJC's do not use list. These are abbreviations that are frequently misinterpreted and have led to serious medication errors.
Can you give some examples?
Sure. Things like U for unit, easily mistaken for 0 or 4, IU for international unit, mistaken for IV or 10, writing QD for daily or QOD for every other day, these are often misread. Using a trailing 0 like 5.0 milligrams instead of 5 milligrams, the decimal can be missed, leading to a tenfold overdose. Or not using a leading 0 like writing 0.5 milligram instead of 0.5 milligram. Again, decimal point issues. And certain drug abbreviations like MS or MSO4 for morphine sulfate, which can be confused with magnesium sulfate, MgSO4. Always write them out fully.
Wow, those seem like easy mistakes with huge consequences.
They are. Using the wrong abbreviation can be dangerous. And of course, correct spelling is vital too. Many medical terms and drug names sound alike. Accuracy prevents confusion and promotes safety.
Okay, factual, accurate.
Wow.
What's number 3?
Third is current. Documentation needs to be timely. Delays can compromise care because the record doesn't reflect the patient's current status.
What needs to be charted right away?
Definitely things like vital signs, pain assessments, when you administer medications or perform treatments, any significant change in the patient's condition, admission, transfer, discharge, or death, and the patient's response to interventions. Those need to be documented pretty much as they happen.
Got it. And number 4?
Fourth is organized. Your notes should be concise, clear, and follow a logical sequence. Think critically about the information. For example, if you're documenting pain, you'd logically include your assessment of the pain, the intervention you provided, and then the patient's response to that intervention. It should flow logically.
Makes sense. And the last one?
Finally, number 5 is complete. Make sure you include all appropriate and essential information according to your facility's standards and policies. Don't leave out critical details.
Factual, accurate, current, organized, complete.
Got it. You mentioned clarity earlier. Is that where military time comes in? Yes, exactly. Most healthcare settings use military time, the 24-hour clock system, to avoid confusion between AM and PM.
Can you explain how that works just verbally?
Sure. Think of a standard clock face. From midnight, which is 0,000 hours, up until noon, the time is essentially the same as standard time, just usually written without a colon and with 4 digits. So 8 a.m. is 0800, 10 to 2 a.m. is 122, noon is 12 over 0.
Okay.
Then from 1 p.m. onwards, you add 12 to the hour. So 1 p.m. is 1300, 1 plus 12. 5:30 p.m. is 1730. 5 plus 12, and 10 to 2 p.m. is 2222, 10 plus 12. It runs all the way up to 2359, 11 plus 9 p.m. It just eliminates any ambiguity about morning or evening.
That seems much safer, especially for medication timing.
Yeah.
Okay, let's explore the actual systems and forms nurses use day to day. What's in the nurse's documentation toolkit?
Well, for routine patient assessment data, nurses often use flow sheets or graphic records, especially within electronic health records, EHRs.
What do those look like?
Imagine sections organized by body system, like respiratory, cardiovascular, neurological. Within each, you might have rows or checklists for things like breath sounds, heart rate, pupil checks, skin assessment, intake-output, activities like hygiene or ambulation. You can quickly check boxes or select from drop-down lists.
Like in Figure 26.3 in the book, showing that respiratory assessment example.
Exactly. It allows for quick entry of routine, repetitive care, and makes it easy to see trends over time, like changes in vital signs or pain scores.
What about more detailed notes?
That's where progress notes come in. This is where different members of the healthcare team record the patient's progress towards resolving their identified problems.
Okay.
One common type is narrative documentation. This is the traditional story-like format. You write out in sentences and paragraphs what happened chronologically. For example, you might write, 1915, adhering to bed rest as ordered, left lower extremity is swollen, calf circumference 76 centimeters, skin warm, reddened area noted on posterior calf, tender to palpation. Oxycodone acetaminophen, 2 tablets given PO for pain rated 710 as ordered. Chris Banks, RN.
So a detailed timeline of events and findings.
Exactly. Then maybe later. 2000 states, the pain medication really helped. Rates pain 410 on 0-10 scale. Left lower extremity elevated on pillows. Chris Banks, RN. It tells the patient's story.
Are there more structured ways to write progress notes?
Yes, there are several structured note formats, often used to ensure consistency and focus. Box 26.1 mentions a few common ones. PIE notes focus on the nursing perspective. Problem, intervention, evaluation. Focus charting uses DR, data, subjective, objective. Action, your intervention. Response, patient's response. It addresses specific patient concerns or changes. SOAP notes are often used by multiple disciplines: subjective data, objective data, assessment, your analysis, diagnosis, plan, what you'll do.
So different frameworks for organizing the same essential information.
Right. Then there's another approach called charting by exception, CBE.
How does that work?
The underlying idea of CBE is that the patient meets all the defined standards of care unless you document otherwise. You use standardized flow sheets and checkboxes, often documenting things as within defined limits, WDL, or within normal limits, WNL.
So you only write a detailed note if something is abnormal.
Precisely. If a finding deviates from the norm, or if there's a significant event or change, then you must write a narrative note explaining that exception. It can be efficient for routine care.
But there are risks.
Yes, the main risk is legal. If something goes wrong and your narrative note explaining the exception is brief or missing key details, it can look like you didn't assess properly or intervene appropriately. That's why, even with CBE, those exception notes need to be thorough. Often, frameworks like SBR, situation, background assessment recommendation, or ISBAR are used to structure these critical narrative notes within a CBE system.
Okay, so efficiency with a need for extra diligence on the exceptions. What about other standard forms in the record?
There are several common ones. The admission nursing history form is used when a patient first arrives. It's comprehensive, gathering baseline assessment data across various areas: health history, medications, allergies, psychosocial status, etc.
The starting point.
Right. Then there's often a patient care summary or CARDEX, though less common now with EHRs. It's usually a computer-generated overview that pulls key information together.
Like Figure 26.4 shows, with sections for demographics, orders, the care plan.
Exactly. It might include demographics, primary diagnosis, current orders, the nursing care plan, scheduled tests or procedures, safety precautions, allergies, code status. It's a quick reference for organizing care and giving handoff reports.
Very useful.
Care plans themselves are also part of the record. These can be standardized based on common conditions or developed using clinical practice guidelines, CPGs. They promote consistent, evidence-based care. Nurses can individualize them, of course, but they provide a solid foundation.
And finally, discharge.
Yes, discharge summary forms are crucial. Discharge planning is an interprofessional process that actually starts at admission. The summary form pulls together key information the patient needs for a safe transition home or to another facility.
What kind of information is typically included, like in box 26.2?
It covers things like step-by-step instructions for procedures at home, precautions to take, signs and symptoms of complications to watch for, names and numbers for follow-up appointments or community resources, a list of current medications, diet instructions, and emergency contact information. It's all about ensuring continuity of care.
Okay, so documentation clearly extends beyond just charting patient status in the main record. It includes other critical communications and events, too.
Absolutely. Think about telephone calls made to providers. Every single call needs to be documented.
What needs to be included?
You need to chart when you called, the phone number called, who made the call, you, or you spoke with or left a message with, the exact information you gave, and any information or orders received. For instance, 0825-2021-2130. Called Dr. Banks's office at 555-1212 regarding patient's increasing pain. Spoke with answering service. Informed that Dr. Banks is on call and will call back K-Day RN. That level of detail is essential.
Very thorough. What about orders taken over the phone?
Telephone orders, TOs, and verbal orders, VOs. These are generally discouraged because the potential for error is really high. They should only be used in urgent or truly emergent situations where written or electronic orders aren't feasible.
And if you do have to take one?
There are strict guidelines, usually detailed in agency policy and box 26.3 in the text. First, only authorized staff can receive them. You must clearly identify the patient using 2 identifiers. Ask clarifying questions if anything is unclear. Write down the complete order or enter it electronically, then read it back verbatim to the prescriber for confirmation.
That readback step seems critical.
It is. You document to or VO the date and time, the order itself, the prescriber's name, and your signature credentials. You also must document that you performed the readback, often noted as TORB, telephone order read back, or VORB.
Okay.
And the provider must then review and electronically sign or co-sign that order later, usually within a set time frame like 24 hours, depending on policy. Here's an example. 0930-2021, TWENSU15, change 4 fluid to D512NS with 20 mL KCl at 100 ml OCHR TO, Dr. Knight K. Day, RN, telephone order read back, TOB.
That TORB documentation is key. Now, what about unusual events like falls or medication errors?
Those are documented using an incident report or occurrence report. These internal agency documents capture any event that's not consistent with routine patient care or standard operations.
Example.
Patient falls, medication errors, needle stick injuries, accidental omission of a treatment, damage to patient property, even near misses where an error was caught before it reached the patient.
What's the purpose of these reports?
Their main purpose is quality improvement. The data is analyzed to identify trends, system issues, or hazards, so changes can be made to prevent future incidents. They are not disciplinary tools.
Okay, quality improvement. Is the incident report part of the patient's medical record?
No, absolutely not. This is a crucial point. The incident report contains confidential information used for internal analysis and risk management. It should never be mentioned, copied, or attached to the patient's healthcare record.
So how do you document the event itself?
You document the objective facts of what happened and your assessment and interventions in the patient's progress notes. Just state the facts clearly and objectively without judgment or labeling it as an incident or error. For example, if a patient fell, you'd chart. Patient found on floor beside bed, assisted back to bed. Neuroassessment performed, findings within normal limits. Notified Dr. Smith, no apparent injuries noted at this time. You document the facts in the patient record, and the analysis of how it happened goes in the separate, confidential incident report. Mentioning the incident report in the patient chart makes it legally discoverable, which you want to avoid.
That distinction is really important. Okay, shifting focus slightly, how does all this detailed documentation impact things like staffing levels or care in different kinds of healthcare settings?
It has a huge impact. Many hospitals use acuity rating systems to help determine staffing needs.
How do those work?
These systems use nursing documentation, primarily your assessments of patient needs and dependencies, to classify patients based on the intensity of care they require. Often it's a scale, maybe 1 to 5, where 1 is relatively independent, needing minimal care, and 5 is totally dependent, requiring intensive nursing care.
And your charting determines that rating?
Yes. Your accurate documentation of things like mobility assistance needed, frequency of monitoring, complexity of treatments, it all feeds into the acuity score. These scores then help justify staffing ratios for each unit, ensuring there are enough nurses with the right skills to safely manage the patient load.
So accurate charting literally helps ensure you have enough colleagues on the shift.
In a way, yes. Now, documentation requirements also vary by setting. In long-term healthcare settings, like skilled nursing facilities, SNFs, documentation is heavily governed by state regulations, TJC, and especially CMS, because of Medicare-Medicaid funding.
What's key there?
The Resident Assessment Instrument, RAI, is critical. It includes the Minimum Data Set, MDS, which is a comprehensive assessment tool completed at regular intervals. The MDS data helps create the resident's care plan and directly impacts the facility's reimbursement level under Medicare Part A. It requires meticulous, accurate documentation from the whole interprofessional team.
Okay, so very structured and tied to funding. What about home health? That seems different again.
It is. In the home healthcare setting, documentation is often done using mobile devices right in the patient's home. Reimbursement, particularly from Medicare, relies heavily on documentation, proving the patient meets specific criteria for skilled care and is homebound.
Is there a specific tool used there?
Yes, the Outcome and Assessment Information Set, OASIS, is required for most adult patients receiving skilled care reimbursed by Medicare or Medicaid. It's completed at the start of care, discharge, and specific points in between. The data collected through OASIS is used for reimbursement, measuring patient outcomes, and quality reporting. Some agencies also use standardized systems like the Omaha system to structure documentation and evaluate care quality.
Makes sense. What about coordinating care for complex patients?
That's where case management and critical pathways often come in. Case management involves coordinating care across disciplines and settings. Critical pathways, also called clinical pathways or care maps, are interprofessional care plans.
How do they work?
They outline the key interventions, assessments, and expected outcomes for patients with specific conditions, like pneumonia or hip replacement, within a designated time frame, day by day, for instance. They help standardize evidence-based care, improve coordination between disciplines, reduce variations in care, and often shorten length of stay.
What happens if a patient doesn't follow the expected path?
That's called a variance. A variance is any unexpected outcome, unmet goal, or intervention that wasn't specified in the critical pathway.
Are variances always bad?
Not necessarily. You can have a positive variance where the patient progresses faster than expected, but more often we focus on negative variances, which occur when activities or outcomes are delayed or complications arise.
Can you give an example, like the one in box 26.4?
Sure. Imagine a patient is on a critical pathway following abdominal surgery. The pathway expects clear breath sounds by postoperative day 2. But the nurse assesses the patient and finds diminished breath sounds in the lung bases, a slight fever, maybe some confusion, and their oxygen saturation, SpO2, has dropped. That's a negative variance. The patient isn't meeting the expected pulmonary outcome.
So what does the nurse document?
The nurse would document these specific abnormal findings: the diminished sounds, fever, confusion, low SpO2, the interventions taken, like encouraging coughing, deep breathing, notifying the provider, administering oxygen as ordered, and the patient's response. Documenting these variances is crucial because analyzing them helps the healthcare team identify trends, potential problems with the pathway itself, and revise it to improve care for future patients.
So tracking deviations helps refine the standard approach. Okay, let's zoom out even further. Beyond individual patient charts, how is technology shaping the bigger picture of nursing practice and healthcare information?
We're talking about the realm of health information technology, HIT. The ultimate goal of HIT is really to use technology to improve the quality, safety, and efficiency of healthcare delivery.
And that involves large systems.
Yes. At the top level, you have the Healthcare Information System, HIS. Think of this as the umbrella system for managing all healthcare-related information in an organization. It typically consists of two main parts: clinical information systems and administrative information systems.
We're focusing on the clinical side, right?
Right. The Clinical Information System, CIS, sometimes called a Patient Care Information System, is the large computerized system that healthcare staff use to access patient data needed for planning, implementing, and evaluating care.
What kinds of systems fall under the CIS umbrella?
It includes various components. There are monitoring systems that might automatically record vital signs from bedside monitors directly into the EHR. There are order entry systems that allow nurses or other staff to order supplies or services. And there are specialized systems for departments like the laboratory, radiology, and pharmacy that integrate with the main EHR.
You mentioned order entry. Is that related to CPOE?
Yes, Computerized Provider Order Entry, CPOE, is a major component of many CISs. This allows physicians and other licensed providers to directly enter orders for medications, tests, and procedures into the computer system.
What are the advantages of CPOE?
There are several big ones. It eliminates issues with illegible handwriting. Orders are standardized and complete because the system often prompts for required information. But maybe the biggest benefit is improved patient safety through built-in clinical decision support, CDSS tools.
How does that work?
The CPOE system can automatically check new orders against the patient's record. It can flag potential drug interactions, allergies, or contraindications before the order is finalized. It might warn if a dose is outside the safe range. This significantly reduces medication errors.
That sounds incredibly valuable.
It is. CPOE also speeds up the process of getting tests done or treatments started, and it can even help with reimbursement by alerting providers if certain procedures require pre-authorization from insurance.
Okay, so CPOE helps providers. What about systems specifically designed for nurses?
Those are Nursing Clinical Information Systems, NCISs. These are designed to integrate nursing science, computer science, and information science to manage and communicate data, information, knowledge, and wisdom in nursing practice. That's the field of nursing informatics. They directly support nurses in their work.
How are they typically designed?
There are two main design approaches. One is the nursing process design. This organizes documentation around the steps of the nursing process: assessment, nursing diagnosis or problems, planning, interventions, and evaluation. It helps generate work lists, document routine care easily, and often incorporates standardized nursing languages like ICNP, NANDI, NIC, or NOC.
And the other approach.
The other is the protocol or critical pathway design. This design facilitates interprofessional management of information using established evidence-based protocols or pathways like the ones we discussed earlier.
What are the overall benefits of using an NCIS?
There are many. They generally enhance the quality and completeness of nursing documentation, often through structured formats and prompts. They can reduce errors of omission. They may reduce hospital costs through improved efficiency. Studies show they can increase nurse job satisfaction. They help agencies meet accreditation standards from TJC. They allow for the development of a common clinical database for research and quality improvement, and they enhance the ability to track patient outcomes.
Are there any downsides or risks?
One risk, particularly with EHRs, is the misuse of features like copy and paste or copy forward. While efficient, blindly copying previous notes without careful review and updating can lead to inaccurate information being carried forward, potentially compromising patient safety. It's crucial to always verify and update any copied information to reflect the patient's current status.
So convenience shouldn't override diligence. You mentioned clinical decision support systems earlier with CPOE. Do nurses have specific versions of those?
Yes, absolutely. Clinical decision support systems, CDSSs in general, are computer programs designed to help healthcare professionals make clinical decisions. They work by linking specific patient data entered into the EHR with a knowledge base, like clinical guidelines or research evidence, to generate tailored recommendations, alerts, or warnings right at the point of care.
Can you give an example?
Sure. A CDSS might alert a provider if they try to order a medication to which the patient has a known allergy. Or, for nurses, a nursing clinical decision support system, NCDSS, might analyze a patient's assessment data, like their Braden score, mobility status, nutrition, and automatically suggest evidence-based interventions for preventing pressure injuries. Or it could prompt for specific fall prevention strategies based on the patient's fall risk score. They act like intelligent assistants, helping ensure care aligns with best practices.
This really highlights how integrated technology is becoming. So this brings up a crucial question. What does all this mean for you, the listener, as a nursing student or a future nurse?
It means that developing informatics competence is no longer just nice to have. It's absolutely essential. Because electronic documentation and health information technologies are now so widespread, all major nursing organizations like the AACN, the NLN, and QSEN emphasize that this competence is a requirement for safe, quality nursing practice.
How is informatics competence defined? Is it just knowing how to use a computer?
No, it's much broader than basic computer literacy. QSEN, the Quality and Safety Education for Nurses Institute, defines informatics competency as the use of information and technology to communicate, manage knowledge, mitigate error, and support decision-making.
So it's about using the technology effectively for patient care goals.
Exactly. It's about understanding how these tools work and leveraging them to improve safety and outcomes. QSEN outlines specific competencies expected even before you graduate, as listed in Box 26.6.
What are some key areas?
It breaks down into knowledge, skills, and attitudes. For knowledge, you need to understand why these skills are essential for patient safety, what kind of information is needed in a shared database, and recognize the benefits and limitations of different technologies.
Okay, the why. What about skills?
For skills, you need to be able to navigate the EHR effectively, use it to document and plan patient care, utilize communication technologies securely, respond appropriately to those CDSS alerts we talked about, use technology to monitor patient outcomes, and find and evaluate high-quality electronic health information for your practice.
And attitudes.
The right attitudes involve valuing lifelong learning to keep up with changing technology, appreciating how technology can support clinical decision-making and prevent errors, being committed to protecting the confidentiality of patient health information, PHI, and valuing the input of nurses in designing and implementing these technologies.
That makes sense. Knowledge, skills, and the right mindset. Let's try to bring this home with a quick critical thinking scenario from the book. Imagine you're caring for a patient admitted with a deep vein thrombosis, DVT. They've been on a continuous heparin infusion, and their latest PTT, a blood clotting test, result shows they are within the therapeutic range. The plan is to transition them to oral warfarin before they go home. All right. You go to administer the scheduled dose of warfarin. You scan the medication package with your barcode scanner, and suddenly a bright alert pops up on the EHR screen. It reads, "Critical lab value alerts. Review most recent PT&R results before administration. You quickly click to view the labs, and the PT&R result, another clotting test relevant for warfarin, is highlighted in red, flagged as a critical value, indicating it's significantly elevated, meaning the patient's blood is too thin and they're at high risk for bleeding.
Okay, classic CDSS alert.
Right. So faced with that alert and that critical lab value,
Right.
what is your most appropriate immediate action as the nurse?
The absolute first step is do not administer the warfarin dose. Hold the medication. That alert is there for a reason, patient safety.
Okay, hold the dose. Then what?
Then you need to immediately assess the patient for any signs or symptoms of active bleeding. Check their IV sites, look for bruising, ask about blood in urine or stool, check their vital signs, and critically, you must notify the healthcare provider immediately about the critical lab value and your assessment findings. You need further orders based on this new information. You would never just override that alert without confirming with the provider.
Perfect. That scenario really shows informatics competence in action, recognizing the alert, understanding its implication, and taking the correct safety steps. So as we wrap up this deep dive, it's just incredibly clear how vital documentation and informatics are in today's nursing world. We've seen how it impacts everything from basic communication and legal protection.
All the way to financial reimbursement, quality improvement, staffing, and crucially, real-time clinical decision support at the bedside. Every entry, every system interaction matters.
It really does.
And understanding these systems, it isn't just about checking boxes or avoiding mistakes. It's truly about leveraging powerful tools to deliver safer, more effective, patient-centered, and evidence-based care in this constantly evolving healthcare landscape. Honestly, your ability to master this domain will significantly shape the impact you make as a nurse.
That's a powerful thought to end on. A huge thank you for joining us today for this exploration. Remember, you're a valued part of our learning community here on The Deep Dive, and we really look forward to digging into more essential nursing topics with you next time.